Good morning, everyone. Can you hear me?
Good morning, ma'am. We can hear you.
Okay. Today I'm going to talk about hyperbilirubinemia in the newborns. Okay, I'm Dr. Sahana. I'm professor in pediatrics. Okay, what do you know about hyperbilirubinemia in the newborn? Is it the same as in the older children or adult, or it is something different? Anyone can answer this. Anything? Anyone? You're all 8 term. You must have finished your pediatric postings. How is it different from the older children? Anyone? So let's see the case scenarios. Okay. Here is a 4-day-old a baby, newborn baby with bilirubin of about 18 milligrams per deciliter. Is this jaundice physiological or pathological? What is the mode of treatment? Okay. The next case scenario is a 24-hour-old male infant weighing 2.4 kg has a bilirubin of 20 milligrams per deciliter. And the mother's group is O positive and the baby is B positive. So what could be the reason for jaundice here? And what is the modality of the treatment here? Okay. So we will see the answers for this at the end of the session. If anyone can answer now itself, you're welcome. Anyone? So what are the learning objectives here? We are going to discuss it under these headings like what is the bilirubin metabolism and the clinical significance of hyperbilirubinemia, why we should worry about that, and the diagnostic approach and the workup, and what is direct and indirect hyperbilirubinemia, develop differential diagnosis, understand management options and the current concepts. Now in this class I am just going to talk about the indirect hyperbilirubinemia that is usually seen in the newborn period. So what do you mean by jaundice? It is nothing but yellowish discoloration of the skin, sclera and mucous membrane due to the deposition of bilirubin. So it is the most commonly seen in the first week of life. So it is usually seen in 80% of the term baby, 60% of term babies and 80% of preterm babies. So when do you see clinically the bilirubin, the jaundice in the newborns? When the bilirubin level is 5 to 7 milligrams per deciliter, you usually see the visible form of hyperbilirubinemia in the newborn period. Now, what is the bilirubin metabolism? So how does the bilirubin is produced? So you should know all these things. So majority of the bilirubin is produced from the destruction of the RBC. That is 75% of the bilirubin comes from the destruction of the RBC. Okay, and also from the ineffective erythropoiesis from the bone marrow and the other heme containing tissues. So the hemoglobin, when the RBCs are lysed, the globin part is utilized, and the heme, what happens? Heme is converted into biliverdin by the enzyme heme oxidase. It is a rate limiting enzyme. Okay, this biliverdin is converted into bilirubin with the help of the enzyme biliverdin reductase. Okay, this bilirubin, what happens is circulates in the plasma bound to the albumin. It reaches the liver. So in the liver, the hepatocytes over the cell membrane, there will be something called ligandins. Okay, these ligandins, they help in the take up of the bilirubin from the plasma into the hepatocytes. Inside the hepatocytes, what happens? The bilirubin undergoes conjugation. So with the help of the enzyme glucuronidase transferase. So now the unconjugated bilirubin is converted into conjugated bilirubin, which is excreted into the intestine. Now in the intestine, some of the conjugated bilirubin is converted into urobilinogen and stercobilinogen. Stercobilinogen is excreted in the stool and urobilinogen is excreted in the urine. But some amount of bilirubin, conjugated bilirubin, and in the presence of the intestinal glucuronidase enzyme is again converted into unconjugated bilirubin. Okay, this unconjugated bilirubin now again enters the circulation and reaches the liver for conjugation again. This cycle is called as enterohepatic circulation. This enterohepatic circulation is more commonly seen in the newborn period. Why it is seen in the newborn period? Because in the first few days, baby's intake may be very less. Elimination of the bile may be delayed because of the poor motility of the gut. So all these factors, and along with it, there will be increased enterohepatic circulation in the newborn period. Okay, so that's how the bilirubin is produced. Now, whenever there is a imbalance is there in the production and the elimination, you get a hyperbilirubinemia. Either it can be in the more hemolysis can be there, or there can be conjugation in the liver, or there it can be excreted, or it can be excreted in the bile or eliminated via urine and stool. So how do you assess jaundice in the newborn period? Before that, why the jaundice is more common in the newborn period? Why I told you 60% of the term babies and 80% of the preterm babies will be having jaundice. So what is the reason for this hyperbilirubinemia in the newborn period? It is because the RBC volume per kilogram is very high in the newborn period. Okay, if you see the newborn in the newborn period, the hemoglobin it will be around 16, 18, and sometimes even 20 up to 20. So the RBC volume per kilogram is very high. And the RBC survival also is very less when compared to the adults. The RBC survival in the adults is the lifespan is 120 days, whereas in the newborn period it is 90 days. So because of this, there is increased destruction of the RBCs. And also there is defective uptake. These most some what happens bilirubin from the plasma, there is decreased liganding and the binding of liganding to other anions. Therefore, there can be decreased uptake of this bilirubin by the hepatocytes. Next, there is decreased clearance because the enzyme glucuronidase transferase is most of the times is immature during the first week of life. Therefore, there is decreased conjugation also is seen. And the final one is increased hepatic enterohepatic circulation. So all these factors, I already told that enterohepatic circulation is more because the decreased gut motility with poor evacuation of the bilirubin. So all these factors will result in the increased production of the bilirubin. So when you assess the babies clinically, whenever it proceeds in the cephalocaudal direction, okay, the bilirubin. So when the face is affected, usually it is around 4. This is Kramer's rule. Okay, face is affected, the bilirubin is around 4 to 8. When the upper trunk is involved, it is around 5 to 6. Lower thighs, lower trunk and the thighs are involved, it is around 8 to 16. So okay, when palms and soles is involved, it means usually the bilirubin is more than 20 milligrams per deciliter, more than 15 it is. So it is a one of the dangerous signs, that is the palms and soles is involved, the baby is having some pathological jaundice. Now, what do you mean by physiological jaundice and a pathological jaundice? So you should know what are the when do you say it is a physiological and a pathological jaundice? When the jaundice appears after 24 hours of age, or when usually in newborns, what happens? The peak intensity is seen by 3 to 5 days. Okay, that it reaches a peak and then it slowly comes down. Whereas in the preterm babies, the peak reaches by 7th day. And the serum in the physiological jaundice, the serum bilirubin levels usually are less than 15 milligrams per deciliter, and they disappear by 14 days of life, and it doesn't require any form of treatment. So these are all the characteristic features of the physiological jaundice. Then what do you mean by pathological jaundice? Usually the pathological jaundice, it occurs before 24 hours of age. Okay, and the rise in the bilirubin levels is more than 5 milligrams per deciliter per day or more than 0.2 milligrams per deciliter per hour, or when the total serum bilirubin, when you take the direct and the indirect component, if any time in the newborn period, if the direct serum bilirubin is more than 2 milligrams or more than 20% of the total serum bilirubin, it is always pathological. Okay, if the baby is having any underlying illness, like if the baby is having sepsis, hypothermia, acidosis, then also it is a pathological jaundice. Then jaundice persisting for more than 2 weeks in the term babies and 3 weeks in the premature babies, it is a pathological jaundice. So how do you approach the jaundice in the newborn period? So what history you want to take in these babies? That is, The family history of jaundice, anemia, splenomegaly, all these things should be taken because there can be a history of a hereditary spherocytosis or hemolytic anemias in the families. Or there is any history of liver disease like galactosemia, Crigler-Najjar syndrome 1 and 2 which runs in the families, and alpha-1 antitrypsin deficiency. Then a sibling with jaundice or anemia, like blood group incompatibility. So what are the blood group incompatibility which is commonly seen with pathological jaundice? That is RH incompatibility and the ABO incompatibility. So what happens in RH incompatibility? The mother is RH negative and the baby is RH positive. During the first pregnancy, what happens? At the time of delivery or if any abortion is there, only a few amount of RBCs get spilled in from of the fetus gets spilled into the maternal circulation, and these they get sensitized. Okay, now the antibodies are formed. These antibodies during the next pregnancy, what happens? They cross the placenta. They cause destruction of the RBCs in the newborn. The newborn, if it is severe enough, it can cause a hydrops fetalis in the newborn baby, or the baby can present with severe edema at birth with anemia and jaundice and the pallor. Okay. Then what happens in ABO incompatibility? In the ABO incompatibility, usually what happens? The mother is O positive and the baby is either A or B positive. So the already formed antibodies, the mother will be having antibodies. They cross the placenta and then they cause a lysis of RBC. So any sibling with history of jaundice or anemia, check the grouping of the mothers. Okay. There can be a blood group incompatibility can be there. Then maternal illness during pregnancy, like congenital viral infections, like torch infections, they can cause jaundice in the newborn period. So inquire about history of fever, rash in the mother. Okay. Then history of any diabetes mellitus in the mother. These children are also prone for jaundice in the newborn period. And some of the maternal drugs like oxytocin, they increase the chances of the jaundice in the newborn period. Then a word about breastfeeding failure jaundice and breast milk jaundice. What is breastfeeding failure jaundice and what is breast milk jaundice? During the first few days, mother may not be having adequate milk output. So the baby may not be getting adequate feeds. So in these exclusively breastfed infants, when you see on the day 3 of life, they will be having more bilirubin, okay, when compared to the formula fed infants. This means because of the failure of the feeding. So because of the decreased lactation, the babies will have high amount of bilirubin. Okay, that is called breastfeeding failure jaundice. And what is breast milk jaundice? Breast milk jaundice is usually starts after the 5th day of life. Okay, and what do you mean by that breast milk jaundice? It is usually seen in 2.4% of cases. These babies after 5th day of life, they start having the increased amount of the bilirubin. So when you continue, these babies are healthy. They do not have any signs of illness. Okay, and these babies, the peaks in the bilirubin level peaks by 2 weeks of age. If you continue breastfeeding, the bilirubin levels comes down by in the next 3 to 12 weeks. Suppose if you stop the breastfeeding, the bilirubin levels abruptly comes down. And then when you restart after 24 or 48 hours, what happens? The bilirubin level may slowly rise, but doesn't reach the previous value. So why it happens? In these babies, they will be having good adequate weight gain, normal liver function, and there will not be any evidence of hemolysis. They will be healthy babies. So this is because of the presence of some substance called beta pregnanidiol or beta glucuronidase like enzyme in the breast milk, which converts the conjugated bilirubin into an unconjugated bilirubin, so which lead to again intrahepatic circulation. So that is the difference between breastfeeding failure jaundice and the breast milk jaundice. Now, what do you examine physiologically? So, in the pathological jaundice, physical examination, you should do now. You have taken the history. I told you what all you should ask in the history. Now, physical examination. See whether the child is premature child. Okay. So, prematurity, the babies are more prone for a hyperbilirubinemia. Then if the baby is small for gestational age, because SGA babies are more, or sometimes on the, what happens, there can be torch infections in one of they can be IUGR babies. So there may be history of torch infections in the mother. Okay, then you see whether the head circumference like microcephaly is there, indicating again some form of a congenital or intrauterine infections. Then collection of any extravascular blood, like what do you mean by extravascular blood collection? The commonest one is cephalematoma, that is collection of the blood in the beneath the periosteum, okay, between the skull and the periosteum. So because of the excess collection of blood, what happens, this blood gets lysed. Once the blood is lysed, again it is taken to the liver, okay. So if it is taken to the liver, what happens, there will be again conjugation. So these babies are going to have more amount of bilirubin. So always in the physical examination, look for any extravascular collection of blood. Okay, the commonest being the cephalohematoma. Then look for the pallor. Associated pallor is there, indicating hemolysis. Then petechiae. You see for any petechiae. Because all these things, petechiae, thrombocytopenia is one of the feature of the congenital infections. Then hepatosplenomegaly, organomegaly is there. Omphalitis, chorioretinitis. So chorioretinitis always because if it is an intrauterine infection or torch infections, look for any features of the chorioretinitis. Okay, then any evidence of hypothyroidism. See, hypothyroid babies also are going to have prolonged hyperbilirubinemia in the newborn period. So always do the thyroid screening in the newborn period. So look for the features of hypothyroidism. Sometimes it can be also a serious sign of underlying illness, like baby can be in this severe sepsis. So what happens if we don't treat the babies having the jaundice? So why we are worried? We are the most dreaded complication is a bilirubin encephalopathy. Okay, that is refers to the acute manifestation of bilirubin toxicity seen in the first week after birth. So the initial signs can be lethargy, hypotonia, baby can be having poor suck that may progress to hypertonia like opistotonic posture, retrocolis, high pitched cry, and eventually there can be seizures and the coma. So kernicterus is a chronic biliary encephalopathy where already it is a pathogenic diagnosis characterized by bilirubin staining of the brainstem nuclei and the cerebellum, but also has to, that's what this is, chronic bilirubin, that is acute bilirubin encephalopathy leading to chronic bilirubin encephalopathy. Here the findings will be athetoid cerebral palsy, developmental delay, hearing defect, oculomotor disturbances including paralysis of upward gaze, that is called Pernaut sign, dental dysplasia and intellectual impairment. Now, usually visual inspection is usually unreliable. If the bilirubin, serum bilirubin is more than like around, if it is more than 12 milligrams per deciliter, visual inspection. So what are these risk factors when, so the risk factors are the baby's gestational age is less than 37 weeks, that is a preterm babies. Collection like significant like cephalhematoma. Okay, then other thing is any immune or hemolytic disease, that is the mother is having if the mother is Rh negative mother, okay, or if the mother is ABO, if there is any ABO incompatibility is there, or when you are checking the age specific bilirubin levels, that is total serum bilirubin level, if it is above the 95th percentile, it is certain charts. 80th percentile, 75th percentile, and the 90th percentile. If it is more than 90th percentile, it is one of the major risk factor. So what workup you will do in these infants? You do take the detailed maternal and the perinatal history. and then you do the direct nose test. The baby looks lethargic. UGR with petechiae, hepatosplenomegaly, microcephaly, then you do the torch assay in these babies. Some babies, they can have G6PD deficiency. They present in the newborn period with sudden onset of jaundice. Okay, specific, especially the male babies. So do the G6PD assay for these babies also. Now, how do you check the bilirubin? Now you have the lab values. Okay, that is you do the serum bilirubin. Okay, is there anything like a non-invasive thing where we can check the bilirubin by directly measuring through the skin? There are certain things called bilirubinometers are present where is a bilirubinometer. What you're seeing this one is a Drager company. So where you there's an optical head is there. It works basing on some optical signals. Okay, you check it on the forehead of the skin and also the upper end of the sternum. What happens? It gives the it is a non-invasive method. It gives the bilirubin values. So what are the advantages? You need not prick the baby and you will get the values within few seconds. Okay. So in the laboratory, how do you assess the bilirubin? The HPLC method is the gold standard, or Vandenberg reaction method is also, but the values varies lab to lab. Okay. And also the bilirubin estimation can also be done based on the spectrophotometry. Now, when do you order for the serum bilirubin levels? If you see the jaundice within 24 hours, or there is a history of ABO in mother being O positive and baby being A or B positive, or if the mother is RH incompatibility, or if you are unsure about your visual assessment, okay? Because after 12 milligrams per deciliter, your visual assessment is not enough. You need to have a blood levels of serum bilirubin. Then during phototherapy, what happens? The skin gets bleached. So your visual assessment is not helpful in such cases. So during phototherapy or after phototherapy, you should check for the rebound jaundice. So you should do serum bilirubin levels. There the physical assessment is not helpful. Now expired carbon monoxide breath analyzer is also there. That is a breath analyzer. See, for every heme is converted into biliverdin. So with production of 1 mole of biliverdin, there is equal amounts of carbon monoxide is produced. So estimation of carbon monoxide can also indirectly tell about the amount of bilirubin formation. But it is not used in our hospital. We usually do the serum bilirubin levels and the non-invasive bilirubinometers are used. Now, how often you want to do serum bilirubin? Once a baby, you diagnosed it as having a bilirubin and you start that baby on phototherapy. Now, how often you want to monitor? It depends upon the severity of the jaundice. Okay, like the baby has having severe jaundice, the initial bilirubin levels are very high. Then you need to prick the baby very often. And also it also depends on the host factors like age of the baby. Like if the baby is less than 24 hours and you see the high bilirubin level, you need to check very often to prevent the baby from the complications. And also gestational age. The lower the gestational age, the chances that baby is having the complications are very high. Okay. Now that is if it is baby is having high bilirubin level, you need to monitor every second or third hourly, or sometimes later changing to 4 to 6 hourly. Once a baby is stable, then you can monitor every to 24 hours. Now approach, you have to see assess the birth weight of the baby, gestation, postnatal age, which is very important. It doesn't give any sense the baby is jaundice. You need to know the gestational age of the baby, term, preterm, birth weight, what is the postnatal age. Ask when the jaundice was first noticed, the clinical condition, whether the baby is well baby or ill baby. Ill baby means there can be underlying sepsis, so work out for the sepsis also. Decide whether the jaundice is physiological or pathological. Look for evidence of kernicterus, that is acute bilirubin encephalopathy in deeply jaundiced newborn baby. This is very important. So how do you look for that? You look for lethargy, poor feeding, absent morals, convulsions, opisthodonic posture. All these things are the signs of the acute bilirubin encephalopathy. Look for that. So once you decide that baby is having jaundice, then you have to start the wavelength phototherapy. When do you say severe? That is called hyperbilirubinemia. Severe hyperbilirubinemia. Severe hyperbilirubinemia is the one when there are jaundice within 24 hours, palms and soles are involved, signs of acute bilirubin encephalopathy. The value of bilirubin is more than 95th percentile as per age-specific nomogram. And the risk factors, as I told you, for bilirubin neurotoxicity, when you assess the neuro risk factors like immune hemolytic diseases and then G6PD deficiency, these babies are the chances that they are having get neurotoxicity is very high. Asphyxia, sepsis, acidosis. If the albumin level is less than 3 milligrams per deciliter, what happens? More and more amount of unbound bilirubin. The bilirubin bound to the albumin doesn't cross the blood-brain barrier. If there is albumin is less, means the unbound bilirubin is more, which readily crosses the blood-brain barrier and causes neurotoxicity. So management, what do you do? It all depends upon the whether baby is term or preterm. So these are the risk factors for the neurotoxicity, which I told you. The presence of isoimmune hemolytic anemia, G6PD, asphyxia, temperature instability, hypothermia, sepsis, and all these things. Now, for term babies, there is certain consensus, like there is a certain chart, phototherapy charts are there. For preterm baby, there are no consensus guidelines when to start for the phototherapy or exchange transfusion. So this is from the American Academy of Pediatrics and also from the AIMS protocol, where based upon the age of the baby or weight of the baby, you start the phototherapy and the exchange transfusion. Like if it is less than 1000 grams, even 5 to 7 milligrams per day is an indication, per milligram per deciliter is an indication for phototherapy. And exchange transfusion at levels of 11 to 13. Okay. If it is a healthy baby. Sick baby, it is even less because we don't know at what levels the baby will have the neurotoxicity. Similarly, like 1000 to 1500 grams, it is 7 to 10, and here it is 6 to 8. So these are the from the IAM protocol and from also from the American Academy of Pediatrics. So what are the aims of management? Why do you want to treat this? To prevent the total serum bilirubin from further rising. And also at the same time, you want to reduce the total serum bilirubin level. You want to stop rising and you want to even reduce the levels. And the main goal is to prevent the neurotoxicity in these children because it is an irreversible damage that is going to happen. So how do you prevent? You start the breastfeeding early. Early and frequent breastfeeding, that is the hydration should be maintained in these babies. And administration of anti-D injection to the Rh negative mother. That's how you can prevent the Rh negative pregnancy in the future pregnancies. If you give the anti-D injection, the baby will have less chances of having Rh hemolytic disease. Now, what are the modes of treatment? One is phototherapy, exchange transfusion, and there are few more modalities are there. So, what is phototherapy? This is the infants. The blue light is given in the blue-green light in the range of 460 to 490 nanometers. The bilirubin absorbs in light at this wavelength, and it is converted into it is converted into soluble forms. Okay, so this one such baby under the phototherapy. This is a blue green light. Now this is a chart where indicates phototherapy. See, there are three lines here. One is blue dotted and the red dotted. So that is a pink one is the infants at lower risk, that is who are more than 38 weeks and well. Suppose a baby at 48 hours of life is a infant at the lower risk. So this is at this level you can start the phototherapy. Okay, this is a chart which guides us to for phototherapy and then which babies are at higher risk. Okay, this is infants at medium risk, that is more than 38 weeks with risk factors. What are the risk factors? I already told, that is immune hemolytic anemia, G6PD deficiency, sepsis, acidosis, albumin levels. These are all the risk factors. Or if the babies are between 35 to 37 weeks and they are well babies, they also come under medium risk. Infants at higher risk are 35 to 37 weaker babies with risk factors. So the level at which the treatment is started is the levels of bilirubin is very less in these babies. Now, what are the various types of phototherapy? There are various phototherapy devices are available in the market, okay, which gives a blue light, blue-green light. So, one is the photofluorescent lamps, okay, then halogen bulbs, then LED lights, light emitting diodes are there, fiber optic light sources are there, okay. Now, first one is when you take the light emitting diodes, these they provide optimal high intensity light in the absorption spectrum of bilirubin, okay. So these are the ones which are available in our NICU in Rajarajeshwari Medical College, light emitting diodes. Fluorescent lamps are one thing, like they have some blue lights and white lights, okay. Uh, this is also used. Next, halogen bulbs are there. The disadvantage of these halogen bulbs is they usually they will cause hyperthermia, and they may cause burns in these babies. And then fiber optic light sources, where the babies can be placed directly under this, okay. They will be especially sometimes in the form of a bilirubin blankets, like that. Coming to the CFL, that is fluorescent lamps, that is they are easily available, low cost, most commonly used in most of the peripheral settings, where 4 blue lights and 2 white lights are available. Next, the LED, which I told you is effective. See, this is the Billy blanket. This is a fiber optic units, Billy blanket. The main advantage is you can keep the baby, continuous breastfeeding can be done, bonding is not hampered, and home therapy can be used with this. Now, how can you increase the efficacy of phototherapy? How can you increase? By decreasing the distance between the phototherapy lights and the baby. So usually normally the light is kept at a distance of 45 centimeters, 30 to 45. In intensive phototherapy, you can reduce it to 15 to 30 centimeters. Okay. So the distance, if you decrease the distance, you can increase the efficacy of phototherapy. Next, skin area exposed. If the maximum skin area is exposed, then the efficacy of phototherapy is increased. So also irradiance. If the irradiance is more than 30 microwatts per square centimeter per nanometer, then the efficacy of phototherapy always is good. Okay. Always you should check the irradiance also when you are putting the baby under phototherapy. Now, how the phototherapy acts? There are mainly 3 mechanisms which bilirubin is exposed. What happens? How the phototherapy acts? One is photoisomerization, structural isomerization, then photooxidation. The main mechanism that acts is the structural isomerization. Here, the bilirubin is converted into lumirubin. Okay, this is an irreversible reaction where the lumirubin is water soluble and is excreted in the urine. This is a main mechanism wherein the phototherapy, the bilirubin comes down in the phototherapy. The other one is a photoisomerization. Here what happens? The 4Z15Z isomer of bilirubin is converted into 4Z15E isomer. Okay, this 4Z15E isomer is excreted, is water soluble and excreted. But this reaction is a reversible reaction. Therefore, this is not the main mechanism of action. So the main one is a structural photooxidation. The third one is a photooxidation. In the photooxidation, what happens? The bilirubin is converted into some small polar products which are excreted in the urine because of the oxidation. So the main thing is a structural isomerization, photoisomerization, where the 15Z is converted into 15E isomer, and the other one is a photooxidation. So this is a photoisomerization. It converts into this is structural isomerization where the bilirubin is converted into lumirubin. This process is irreversible. Okay. And the final third thing is it's the least important reaction for lowering the bilirubin levels. This is a photooxidation method. Now, care of the patient in phototherapy. How do you want to take care of these babies? It's not that you keep the baby under phototherapy and go off. So the baby should be turned every 2 hours so that more and more area of the skin is exposed and the efficacy of phototherapy is increased. The second thing is you should put the baby eye patch. I have seen the here as shown, in the first figure. Here the baby's eye patch is put. Why you want to put? Because this light, ultraviolet light, is going to harm the retina. Therefore, the baby's eye should be covered in these babies. Okay, and even the if it is a male baby, the genitalia should be should be covered because it may cause germ cell mutations. And you should take care that you should not occlude the nares, otherwise the babies can have breathing difficulty. Then infants can have temperature instability. There can be hyperthermia can be there or hypothermia can be there. So make sure the temperature of the baby is maintained. Next, finally, the infant should be weighed daily because some babies they can have insensible water loss can be there. The babies may go into dehydration. So monitor the weight daily and also the urine output, which tells about the hydration status of the baby. So weight should be checked daily, these babies. So when do you want to discontinue phototherapy? If the serum bilirubin falls 3 milligrams below that of the level which has triggered the initiation of phototherapy, you can stop the phototherapy. Sometimes what happens, there can be rebound hyperbilirubinemia can be there. So you need to take the sample 12 to 24 hours after discontinuation to see if there is someone has. Please unmute the mic. Mute the mic. Now, is there any role of prophylactic phototherapy? Prophylactic phototherapy. So prophylactic phototherapy is indicated in special circumstances, especially extremely low birth weight infants, where even the amount of 5 milligrams or 7 milligrams per deciliter, like less than, when do you say extremely low birth weight? Infants less than 28 weeks or less than 1000 grams, they are extremely low birth weight. Okay, so a severely bruised infant, you can start the prophylactic phototherapy in these babies. Now, you must have heard that the grannies will be telling, keep the baby under the sun, the jaundice will go off. Is there any role of sunlight? Yes, sunlight does contain the ultraviolet rays, but this ultraviolet rays, if you keep the baby under the sun, what happens? There are risks that baby can have sunburn, and therefore this is not the optimal mode of treatment, and this should not be advised. The baby may get, if you keep it under the early morning sun, what happens? The baby may become hypothermia. The later part of the ultraviolet rays, if you want and you want to keep it, the baby may get sunburns. So this is not the treatment mode. So never advise them to keep the baby under sun. So there are some effects of phototherapy also. So what is it? That is, there can be insensible water loss because of hypothermia, and there can be watery diarrhea can be there, and calcium can decrease. It can cause retinal damage. That's why you ask the patient to keep it eyes covered. It can cause bronze baby syndrome, especially bronze baby. What do you mean by bronze baby syndrome? If the suppose the baby is having direct hyperbilirubinemia and you keep the babies under the phototherapy, the photooxidation products will get deposited in the skin and they cause pigmentation. This is called a bronze baby syndrome, especially the conjugated, if the baby is having conjugated bilirubinemia and you keep the baby under phototherapy. Okay, and if you keep the baby under phototherapy, what happens? The maternal bonding is affected. That's one of the side effects. So you all continue while the babies on phototherapy, do not stop breastfeeding. Continue breastfeeding to these babies unless the levels are very severe, like that in the exchange, when it is at the exchange level or when you are waiting for exchange transfusion. The second mode of treatment is a exchange transfusion. Now, what do you mean by exchange transfusion? Suppose the bilirubin levels are so high, that is baby is having acute bilirubin encephalopathy, or the serum bilirubin is in the exchange level ratio. That is when there are certain graphs which tell you when to do exchange transfusion. If it is in that range, you do the exchange transfusion. So exchange transfusion, you remove the baby's RBCs, and then the baby's RBCs are usually coated with the antibodies. Okay. So you remove the antibody coated baby's RBC are partially hemolyzed, and also at the same time you also remove the bilirubin, and you replace them with donor RBCs which are lacking the sensitizing antigen. Okay. And also at the same time you remove the bilirubin from the plasma, and also giving a fresh albumin will be there in the exchange blood. So this albumin binds whatever the remaining bilirubin is there, it will bind to it. So within half an hour after the exchange, the bilirubin levels return to 60% of the pre-exchange levels. Why it happens? The bilirubin, it represents a rapid influx of bilirubin into the vascular space, which will be in the cells. The cellular bilirubin will come out now. There is circulation. Now, what are the indication for exchange transfusion? When the phototherapy fails and bilirubin reaches the toxic levels. The important thing for exchange is always acute bilirubin encephalopathy is one of the indication for you to the bilirubin exchange transfusion. Then to correct anemia and improve heart failure in hydropic infants in hydrohospitalism with the hemolytic anemia. Okay, I told you if there is RH incompatibility, the baby can present with hydrops that is collection of the fluid in the third spaces like the pericardial, abdominal cavity and the pleural space and the skin even in the skin. So that is hydrops. Then stop hemolysis and bilirubin production by removing the antibody and sensitized RBCs here. Then all infants should be under, even when you are doing continued given exchange transfusion to the babies, after finishing the transfusion, you should continue to give the phototherapy to these babies. So this is the, what do you say, this is a, yes, this is a graph which tells when to do the exchange transfusion for the babies. Now, early indication is if the cord bilirubin is more than 4.5 milligrams per deciliter cord bilirubin and the hemoglobin is less than 10 milligrams per deciliter. It tells that the baby within next few hours the bilirubin rises rapidly and then may go in for the bilirubin neurotoxicity. Or if the bilirubin level is rising more than 1 milligram per deciliter per hour despite phototherapy, then also it indicates a indication for exchange transfusion. So how do you do exchange transfusion? So you take a three-way. Here the blood is from the, you put the tube in the UVC, umbilical vein catheter, and this is from the blood bag. So you draw the blood from the blood bag and then push it into the baby like through the UVC. Like you take in aliquots, small aliquots like 5 ml initially, then later on you can increase to 10 ml. Then in the same thing you pull out some 5 to 10 ml of blood and then discard it into the waste bin. So this is the method where you do exchange transfusion. So usually the RBCs with what you do exchange is usually should be less than 7-day old blood should be taken. So what type of blood you want? What is the choice of blood? If it is the RH isoamination, it should be RH negative, O negative blood should be done. Okay. And if it is ABO incompatibility, it should be RH compatible and blood group O, and it should not be not that of the baby's blood group. Okay. And this should be suspended in AB plasma. RBCs, PRBC should be suspended in AB plasma. Other conditions like G6PD deficiency, non-hemolytic, you take the baby's group and RH type, cross match with every time you have to cross match with mother's and the baby's blood. Okay. So what is the volume of the blood? The normal volume of the infant blood is the newborns is around 80 ml per kg is a normal volume. So you take the double volume, that is 160 ml per kg is taken and you do the exchange transfusion. That is double volume exchange is done here. So what do you mean by double volume exchange? Suppose the baby is weighing around 2 kgs. So double volume is 160 ml per kg. That is 160 into 2. That is 360 ml of blood is required. So that it will remove at least 90% of the bilirubin from the circulation. Exchange transfusion usually involves a double the volume of the infant. That is double volume exchange. Okay. This I told you. So this will replace around 87%, 87 to 90% of the infant's blood volume with the new blood. Now there are certain complications associated with exchange transfusion. It is not that simple. Okay. The babies can have, because it is a citrated blood. What you are taking is citrated blood. The baby's calcium can become low. Okay. There can be hypocalcemia. Hypoglycemia can occur in these babies. Okay. Because it is a stored blood more than 7 and because of the preservatives. So baby can have hypoglycemia. So in between check the sugar levels, and if it is low you need to push the dextrose. It can cause acid-base disorder. That is, if it is a old blood, the pH of the blood can be altered. Then hyperkalemia. If you take older blood more than 7 days, what happens? RBCs in that blood get lysed. All the potassium, intracellular potassium comes out and it can cause hyperkalemia in these babies. Okay, the baby sometimes can go into congestive cardiac failure. Bleeding can happen. Then infections is one of the important cause that has to be kept in mind. Okay. Then temperature dysregulation and rarely graft versus host disease can happen. These are the complications of exchange transmission. Now, what are the newer modalities of treatment? That is, some of the things like phenobarbital, you would have heard is an anticonvulsant drug. But the mechanism of action, how the phenobarbital acts is that it induces the enzyme glucuronidase transferase. It matures, helps in the maturation. So when you give it to the babies, what happens? This will cause the maturation of the glucuronidase transferase enzyme in the newborn. So it can actually help in the conjugation of the bilirubin inside the liver. So the dose is 2.5 milligrams per kg per day for 5 to 7 days can be given. Where do you want to give it? It is given in Crigler-Nazar syndrome type 2 and Gilbert syndrome it can be given. Next, metalloporphyrin links tin, zinc. What happens? This acts at the level of the heme oxygenase. It inhibits the enzyme heme oxygenase. So that the conversion of heme to bilirubin doesn't happen if the enzyme is blocked. So trials are being done on this also. Next, albumin. Because as I told you earlier, the level of albumin less than 3 grams per deciliter is one of the risk factor. So by giving albumin, more and more bilirubin binds to the intravenous, binds to the albumin, and then neurotoxicity is prevented. Okay. And the important thing is IV immunoglobulin. So this is very effective drug. It is given in RH and ABO hemolytic disease. Okay. This reduces the need for exchange transfusion. Okay. So what is the dose? It is 0.5 to 1 gram per kg or 2 hours repeated in 12 hours if necessary. So when do you give it? When there is isoimmune hemolytic disease and the TSB is rising despite your phototherapy, or if the TSB is within the 2 to 3 milligrams per deciliter of the exchange, then you can give IV immunoglobulin. How does it act? What is the mechanism? It blocks the FC receptors on the macrophages. So thus it prevents the hemolysis of the antibody coated RBCs. It prevents the hemolysis by blocking the FC receptors in the macrophages. Now there is some few studies have quoted that when you give UV immunoglobulin, you have to see this. There is an increased incidence of necrotizing enterocolitis in term or late preterm infants who have been treated with IVIG. So a question of caution here. So you have to see this. So continue breastfeeding for these babies who are on phototherapy. So if you cannot take the baby out of phototherapy, then you can give the express breast milk can be given to these babies. So when can you discharge these babies? When they are feeding adequately, when the trend is towards the lower values, and before discharge always do the auditory function test. That is BERA has to be done in these babies. In these babies who are severe jaundice. Why? Because the bilirubin damages the eighth nerve, so they can have deafness. If you don't pick up the deafness in the early stage, what happens? The babies can have language problem and later speech difficulty can be there. So always do this test in these babies. Now coming to your case scenarios, it's a newborn baby, 4-day-old with bilirubin of 18 milligrams per deciliter. It's a 4-day-old baby. Is this jaundice physiological or pathological? Anyone tell what's the mode of treatment for this? You can unmute yourself, please. Anyone? Please answer. Yes, Pratisha, answer now. Anything above 15 milligrams is always pathological. Okay, it may not, though it has started after you have picked up on 4th day after 24 hours, it is in the exchange phototherapy range. So the mode of treatment is phototherapy. The second question is 24-hour-old male infant weighing 2.4 kg. The weight is also less here. Okay, and the bilirubin is 20 milligrams per deciliter. That is on day 1, the baby is having 20 milligrams. So it is very high. When you see the risk factors, the mother's group is O positive and the baby is B positive. So the baby is having which incompatibility? Is having ABO incompatibility. Okay. So what is the modality of the treatment? Start phototherapy. Observe the baby. If it is rising, you may have to go for exchange transfusion for this baby. Okay. So what is the take home message? Jaundice is the most common cause of common disease that is seen in the babies. So before discharge, you see the baby's pre-discharge bilirubin level should be seen and risk factor should be assessed and ask the baby to come back either at 48 hours, 24 hours or 48 hours based on the risk factors. Otherwise, the readmission is very common. Okay. And then visual inspection is unreliable if the bilirubin levels are more than 12 milligrams, 12 to 14 milligrams. So you need to do serum bilirubin levels. So inadequacy of breastfeeding is a common cause of exaggerated jaundice during the initial few days. Next, TCP is an usual adjunct, that is you can use it, but it cannot replace the blood serum bilirubin estimation. Okay. Then phototherapy remains the mainstay of treatment for this in the hyperbilirubinemia in the newborns. Okay. Then exchange transfusion is done. I have told you the indications and what type of blood is usually required for the exchange transfusion. And there are certain newer modalities like phenobarbital, metalloporphyrins, albumin, and IVIG is there. Any doubts you have? Anyone having any doubts? Anyone is having doubts? Please, you have still some time. You can ask me. So what is what is the difference between physiological and pathological? Can anyone tell? Somebody answer please. I should know whether you understood or not.
Ma'am, pathological has levels of bilirubin more than 15 mg per day.
Within 24 hours. Okay. When there is a history of RH negativity in the mother. Then palms and soles are involved. The total serum bilirubin is more than 95th percentile of the on the bilirubin nomogram. Okay. Any doubts? If there are no doubts, I will stop the session here. Okay. Thank you all. How to stop this? Stop recording. Ah.
I also don't give interest. This is also. So take